Hi, I'm Justin Golub. I'm an otolaryngologist at Columbia, and I'm excited to lead this panel on hearing loss and dementia, separating fact from fiction. I'd like to thank everyone for staying late on Saturday night, especially those on the East Coast, to hear us talk about presbycusis. I assure you this will be more exciting than anything on Netflix. So I'm going to introduce the topic, and then we'll move on to some panel talks, and then finally we'll end with some Q&A. Disclosures. So I am an otologist, neurotologist, and I spend about half my time thinking about the brain effects of age-related hearing loss. You just heard an excellent talk from one of my mentees, Alex Reyes, who's applying for otolaryngology on the relationship between hearing loss and brain beta amyloid. And we'll discuss that in a little bit more. And then in the other half of my life, I'm a clinician and I'm an enthusiast for endoscopic ear surgery. And we have just a tremendous panel tonight. I'm excited to have some absolutely wonderful guests. We'll start out with Katie Brewster, who's a psychiatrist and T32 research fellow at Columbia, excellent collaborator of mine on several projects. Next up, we have Nick Reed, who's substituting for Jennifer Deal, who is on your program. He's an assistant professor at the Cochlear Center for Hearing and Public Health at Johns Hopkins. And then we have Carrie Nieman, who's also an assistant professor at the Cochlear Center at Johns Hopkins. And then finally, Margaret Pichora-Fuller, professor emeritus in psychology at the University of Toronto. So clearly, age-related hearing loss, much more exciting than anything about Netflix. And the reason it's so exciting is because it's so important. It's important because everyone here is going to get it if you're lucky enough to live long enough. And all of your patients will get it, so you should care about it. This is a graph that shows how common it is. On the y-axis is pure tone average, which is a good single number that encapsulates your level of hearing loss. And on the x-axis is age in half decades. And so the red line delineates what's typically considered normal hearing from hearing loss. And you can see by age 70, the majority of people have age-related hearing loss. And in fact, the relationship between age and hearing loss is very predictable. We modeled this in a recent paper, and it's proportional to the square of your age. So hearing loss accelerates very predictably as you get older. So now let me just summarize everything I've spoken about so far tonight. Age-related hearing loss, incredibly common, over 80% of people who are over 80. But at the same time, the treatment level is very low. Under a quarter of people who are over 80 actually do anything about it. And I find this disparity questionable. So I like to give this analogy. Pretend you're an internal medicine doctor and a patient is in front of you with this glucose value and the patient has no symptoms. You would probably say to them, hey, you should treat your diabetes, you should take insulin. And if the patient said, I'm asymptomatic, would you shrug and say, have a nice life? Of course not. You'd say you absolutely must use insulin. And every other doctor that saw that patient would say the same thing, because we know from years of epidemiologic research that high glucose causes all these terrible things. Now switch hats and pretend you're an otolaryngologist or an otologist or an audiologist. And same scenario happens. Patient comes in, this is on your desk. Patient says, I have no symptoms. I don't know why I'm here. This is the typical audiogram, of course, for age-related hearing loss, which is usually asymptomatic in the beginning because it progresses so slowly. And you would tell the patient, I recommend a hearing aid. And they may also say, I don't want to do anything because I have no symptoms. And in real life, what would typically happen is you'd shrug and say, okay, I recommend it, but suit yourself. And that's it. The discussion would end. No other doctor would ever bring it up, and that would be that. Why the enormous difference in how strongly we recommend treating diabetes compared to how strongly we recommend treating age-related hearing loss? The reason is we don't really know what this does. We don't really know what the broader health effects of age-related hearing loss, what they are. Until very recently, we think we are starting to know. And so when we talk about causation, we talk about exposures and outcomes or diseases. So for example, the exposure in the previous example is a high glucose, and the disease would be a stroke many years later. For most of hearing loss clinical research, hearing loss has been treated as the disease, and we've studied all of these exposures that can cause the disease of hearing loss, like genetics and noise. And the reason is if you could prevent these exposures in red, you could prevent hearing loss, which of course we all value in this room as something really important. But what I think is much more interesting is to flip the relationship and consider hearing loss as the exposure and ask the question of, if you have hearing loss, what happens next? Do you get cognitive impairment? Do you get dementia? Do you get depression? And so this afternoon or evening, what we're going to be talking about is causation and relationships between exposures and outcomes. So I just want to give a little tutorial on this, and then we'll get on to the panelists. So here is hearing loss on the left is the exposure, cognitive decline on the right is the outcome. And if these two things just go together, we say that there's an association, okay? So if hearing loss causes cognitive decline, the direction is from left to right. It's also possible that cognitive decline could cause hearing loss, theoretically, I don't think it does. And then the direction could be bidirectional. If you don't know which way the direction is, or if there's a direction, you simply just say association. Now, there's also the possibility that something else could cause both the exposure and the outcome, and that's what we call a confounder. And in these epidemiologic studies, we try to mathematically, statistically control for this by doing what we call adjusting. So say hearing loss does cause cognitive decline, it would be doing so through some mediator, or AKA mechanism. So when you hear mediator, think mechanism. Both start with M, so that's easy to remember. So how might age-related hearing loss be related to cognitive impairment and dementia? So one possibility is you could have these confounders. There could be no real relationship, and things like little strokes could cause hearing loss, little strokes could cause dementia, and that's the extent of the relationship. There's no causal relationship, in other words. Aging clearly is a confounder, and then there could be unknown things, unknown neurodegenerative mechanisms. So what I put here in purple, these are the confounders, and it's important to control for these in any epidemiologic studies. Now, it's also, of course, possible that there is a causal relationship. Age-related hearing loss could cause cognitive impairment and dementia. One way it could do this is through a change in brain structure, like the temporal lobe could shrink, and that could have cascading consequences on the rest of the brain. Age-related hearing loss could also reduce socialization, which over time could lead to worse cognition, and our panelists will talk more about that. And then finally, age-related hearing loss could increase cognitive load, which means that if you have a lot of hearing loss, you use all your brain power just to decode the words and just hear them. And by the time you figure out what the words are, the speaker is 3 sentences beyond, and you don't have any brain power left to make memories or process the higher content of the speech. And then finally, there could be reverse causation. So I'd like to move on to our panel. And first I'll introduce Dr. Katie Brewster, who's a T32 research fellow in psychiatry at Columbia University and one of my excellent colleagues. And she's going to be talking about neural mechanisms linking hearing loss to depression and cognitive decline.
So thanks, Justin, for that introduction. So today I'm going to be talking about the neural mechanisms linking hearing loss to depression and cognitive decline. So maybe I can take a moment to explain why a psychiatrist is here at an otology conference tonight. And as a geriatric psychiatrist, two of the most common disorders that we see are late-life depression and cognitive impairment, which are disabling conditions and often present together. Similar to cognitive impairment, treatments that we have for depression don't work so well in older adults. So this is work done by a mentor of mine, Stephen Roos, who found that citalopram, an antidepressant, actually worked no better than placebo in late-life depression. Hearing, on the other hand, is a common condition in older adults that you all know way better than me how to treat effectively. Hearing loss has been linked to the development of depression, and in addition, hearing loss and depression are two of the most significant potentially modifiable risk factors for dementia. So maybe by treating hearing loss, we can help kill two birds with one stone. So in order to understand why people with hearing loss may develop depression and dementia, we wanted to do a little bit of digging into the neuroimaging literature. So this is work done by Franklin and Hopkins, who found that people with hearing loss had accelerated brain atrophy than people who don't. This was observed in the whole brain and specifically in the temporal regions, which are important for auditory and language processing as well as for memory. In addition, we've been learning from you hearing colleagues or hearing experts that as hearing capacity declines, older adults must expend increasing effort to discriminate speech in the presence of background noise. And this is work done by Jonathan Peel, who's been able to see the effect of effortful listening on the brain. And in the presence of degraded speech, people with hearing loss can have abnormal brain activity in areas important for attention and cognitive control. And in addition, it appears that people with hearing loss may actually process emotion differently. So for example, an older adults with hearing loss can be less accurate and slower at identifying emotional sentences. This effect can also be observed in the brain, as people with hearing loss can demonstrate decreased activity in areas important for emotion, such as the amygdala and parahippocampus when listening to emotional sounds. So based on this literature, we came up with a model linking hearing loss to neuropsychiatric dysfunction. As we just reviewed, studies have found effects of hearing loss on brain areas important for cognitive and emotion processing. However, really less work has been done in understanding how these brain effects can lead to neuropsychiatric problems such as depression. It's possible that decreased cognitive reserve or cognitive load, as Justin was talking about, from effortful listening, can lead to a cognitive problem known as executive dysfunction, which I'll talk about in a second, and as a significant risk factor for late-life depression. It's also possible that abnormal emotion processing in hearing loss is why we see an increased risk for depression, but clearly we have some more work to do to test this model. So we first wanted to make sure that hearing loss was in fact linked to executive dysfunction. So executive function is a cognitive function that is related to working memory and self-control. And some of you may be familiar with the Stroop test. It's a classic assessment of executive function that involves naming the font color of a printed word that is incongruent from the word. So for example, identifying the color yellow when the word says red. Psychiatrists care a lot about executive function because it's associated with a poor prognosis in late life depression. So this is data that comes from a large multi-site treatment study of older adults with treatment-resistant late life depression. About half of them had hearing loss. And we found that the higher PTA was associated with worse executive function as well as dementia. And interestingly, the cognitive problems were pretty much isolated to that of executive function and not for other domains, which was consistent with our model. So we were also interested in understanding how treating hearing loss may be helpful for depression. So this was a small randomized controlled trial done by my mentor, Brett Rutherford at Columbia. So he recruited older adults with moderate to severe hearing loss and depression who were randomized to an active hearing aid, which was fitted as per treatment as usual, or a sham, which was fitted for a flat 10 decibel gain. Both were augmented with antidepressant medications and followed them for 12 weeks, after which time measured neuropsychiatric symptoms. So when you look at the clinical outcomes before and after hearing aids, after 12 weeks of hearing aids, we saw improvements for active hearing aids for a couple of cognitive domains, including executive function, as we would expect, as measured by the flanker test. Immediate memory also improved. We also saw improvements for depressive symptoms as measured by the Hamilton Rating Scale for depression. And when we combined data from a smaller pilot trial with similar methodology, we saw almost a 4-point improvement in the Hamilton for the active versus the sham hearing group, so, which is about the same size you can see in some antidepressant trials, suggesting that hearing aids, at least in this trial, did seem to help depressive symptoms and improve cognitive functioning in older adults. So when we evaluated structural MRI in these participants before we gave them hearing aids, worse hearing ability was associated with atrophy of the anterior transverse temporal gyrus, which houses the primary auditory cortex. And in addition, when we looked at diffusion tensor imaging, we see that impaired speech discrimination was associated with worse integrity of the SLF. The SLF is a white matter tract that connects the frontal lobe to the parietal lobe and is important for executive function, but as you all probably know way better than me, it's also important for auditory processing. So these findings were consistent with our model. We also looked at the functional brain activity during a task called the Simon task before and then after hearing aid use. And I don't want to get too caught up in the weeds here, but the Simon task is similar to the Stroop test, but with arrows on a screen. And it's designed to activate brain areas important for executive function, such as the cognitive control network. So we observed that a baseline here in B, subjects with worse speech discrimination had lower activation of the cognitive control network, consistent with our model. And then D, these sample sizes are very small, but I wanted to show you that after 12 weeks of hearing aid use, we actually observed increased activity of the main regions of the cognitive control network for those who got active hearing aids versus the sham group who continued to decrease over time. So the results of this pilot study suggest that, at least in our study, hearing aids may have adverse effects on the brain, that treating hearing loss may be helpful for mood and cognitive symptoms, and that we may be able to see this reflected in brain activity in the cognitive control network. So I'll let others continue our discussion today, but I wanted to thank our team at Columbia, my mentor, Brett Rutherford, and of course, Justin Golub for his wonderful collaboration on these studies. Thanks.
Hi, I'm Nick Reed. I'm an audiologist at Johns Hopkins Bloomberg School of Public Health in the Department of Epidemiology. I'm giving this talk on behalf of Jennifer Deal, who couldn't make it tonight. The title of the talk is Epidemiologic Inference, and what Jennifer had planned to do was sort of talk a little bit about looking at these studies, linking hearing loss to cognitive decline, really, and going past just the findings and thinking about, well, how does epidemiology in general at the population level think about causality? And so we're seeing all the time now in the media, including really, really high-end media outlets like this article from the New York Times, for better brain health, preserve your hearing. And I think it begs the question for us, is it true? What's the evidence? And how do we interpret that evidence? This article is particularly saying, preserve your hearing, but there's also a lot of articles that say for better brain health, treat your hearing, right? So they see a study linking hearing loss and cognitive decline and immediately say that must mean we should treat it. And I'll get to that in a few as to, is that really a true thing we can conclude? And so what even is epidemiology, and what's the point of it? It's the study of how a disease or another state of health is distributed in a population and what factors influence or determine that distribution. And I think there's some fundamental tenets here for epidemiology. One being that epidemiologic research is science at the population level. And two, we fundamentally have to believe that health and disease are not random, to look at anything at the population level and believe what we're seeing. And this goes back to John's Graunt's work. This is from 1662. He actually published these bills of mortality, looking at mortality due to different causes in a town in England, particularly London, but a specific subsection of London. And what they saw over time is that mortality is not completely random. There's sort of a cyclical regularity to different causes. And this was not really understood at the time. But after looking at it, it meant that mortality could be anticipated and we could detect outbreaks. So we could actually go backwards and say that the excess death was due to a certain exposure of some kind, particularly in the case of infectious disease. And what's the value of doing this at the individual level when we try to understand sort of this constellation of exposures and behaviors and how they relate to health or disease? It's difficult to discern exactly what a cause and effect might be. But at the population level, we may start to see patterns that become clearer and clearer. So really, when we do an epidemiologic study, there's three possible explanations for what you're seeing. And the first really is it's just chance. We're looking, again, at a population level, and we want to make an inference to the entire population. But the sample we've chosen may not truly represent that population, and it's just a chance that the sample we chose happens to have a certain correlation, right? And this is really, chance is the word we use, and we talk about uncertainty, such as confidence intervals or p-values, but what we really mean is it's sampling variability. It's not feasible to look at the entire population, and that variability of the sample we chose just happens to not be correct. The other area that we might find, something that might explain what we found, is bias. We may believe that there is bias in something like selecting the participants, or it could be an information bias, which is generally measurement error. So, the way in which we measure the exposure or the outcome affects our findings. Or there's confounding, which is really these other important factors that relate to the exposure and the outcome that we're not, some people use the word controlling for or adjusting for in our models. And so chance happens at the statistical level. Chance is something we can estimate for uncertainty. Bias and confounding are things that come from the epidemiologic level, thinking about how we design our study and how we account for different variables, and it comes from clinical knowledge, Confounding can only be accounted for if we know something from the clinical level. So for example, we know, as Justin pointed out in the beginning, age is related to both hearing and cognitive decline. So we have to account for that confounding. And so we can think about sort of designing this study to a certain extent. We can balance the bias and make an informed inference. We can attempt to adjust for and design the study to protect from that bias. It's not, really whether or not there is bias in the end, it's how much is present and how we communicate that. And so that gets us closer to the idea of cause that Justin put forward, A causing B. When we think about whether or not causality is there, we use Bradford-Hill's criteria. We start to think about the strength of the association, the dose response of the relationship. When you cease the exposure, does the outcome then cease? Is this plausible? Do we find the same findings over and over again? And I think what's important is we're not looking at any one specific area of causality. We're looking at all of these together, which really means that no single study can actually determine causality. We have to have multiple studies in repeated different populations to really say that this is causal. There's a rare case with definitive clinical trials, but that is rare. And so we can't account for all bias. And a good example of this is with hearing aids and dementia. We consistently believe that hearing aids may delay dementia or be protective, but hearing aid use is fundamentally different. Hearing aid users, are fundamentally different from non-users. They're highly educated, higher SES. They also just have different healthcare access and utilization patterns. And these are protective against dementia just as much as hearing aid use might be. And we can't statistically tease these apart. It's a bad data in, bad data out. And so we have to make a judgment call that even if we see this over and over again in studies, it may not be true. We need an actual randomized clinical trial to say whether or not this is causal and it truly modifies the association. So I think the take-home message is there's no specific checklist for interpreting a single epidemiologic study. We have to look at all data. Each study is going to have strengths, and we have to understand how that bias and chance was communicated. There may be more than a correlation, but not always a cause when we think about the bias within a given study. And no study is going to be perfect, but taken together, it can be informative.
Hi, good afternoon, good evening. I'm Carrie Nieman. I'm an otologist at Johns Hopkins and also at the Cochlear Center for Hearing and Public Health with Nick. I'll be sharing some of our work thinking about the intersection between hearing loss and dementia. And what do we know from a public health perspective? And why does hearing loss and hearing care in the setting of dementia matter? A lot of what I'll be talking about tonight is funded by the NIH. So just to give credit there. And so when we think about hearing loss, really specifically age-related hearing loss, how we think about it has really shifted over the past decade. So when I'm thinking about it as a clinician, in terms of when I'm counseling a patient, and then when I'm thinking about it as a researcher, we're really thinking about it in terms of healthy aging. Hearing loss has been independently associated with negative outcomes in almost every aspect of aging. And a lot of the interest and a lot of what we're already talking about in this panel has been this connection between hearing loss and dementia. And while it's really exciting, I'd argue it's not the only thing that we need to be thinking about in terms of hearing loss and dementia as otologists and neuro-otologists. Something else that we need to be thinking about is if we truly want to care for our patients over the lifespan, we need to be thinking about hearing loss when it's occurring in the setting of dementia. So what does it mean in terms of hearing loss and hearing care for those individuals, for our patients who already have some degree of cognitive impairment? And so with that, we'll talk a little bit about what we know about dementia. So in a lot of ways, some of the things around dementia is similar to what we see with age-related hearing loss. For dementia, the single biggest risk factor is age. And so we see roughly doubling of the prevalence of dementia with each decade of life. And that's similar to what we see with age-related hearing loss. And while the overall prevalence is not as high as what we see with hearing loss, The thing I think that is always striking to think about is that 1 in 3 older Americans will die with a diagnosis of dementia. Certainly not as common, but it is something that is highly prevalent. The other thing that I think is very important that I don't think gets enough attention is that among older adults, the prevalence of dementia varies by race ethnicity. And what we know is that among racial ethnic minorities, the prevalence of dementia is much higher, and really in particular among African American older adults. It's been this way for decades and is really a high priority area focus in terms of understanding and addressing why these differences exist. So if we're going to be thinking about hearing loss and the intersection of dementia, we have to be considering racial ethnic minorities in that, in terms of who's included in the research that we're doing and what we're thinking about in terms of approach to hearing care. So just like we think about hearing loss matters for older adults, or we believe that it matters for aging among older adults in general, we're beginning to think that hearing loss matters in terms of healthy aging or aging for persons living with dementia. And so there's increasing understanding that sensory loss may put individuals at increased risk for negative outcomes that are both important for persons living with dementia as well as their care partners. So we'll start really at the beginning in terms of thinking about from a population level or public health perspective. We'll start with a basic question of how common is hearing loss among persons living with dementia. And so we'll look at one particular cohort. It's called the ERIC cohort. It's at 4 sites across the country. It is not a nationally representative cohort, so to keep that in mind. But something that's really unique about this cohort is that it has adjudicated cognitive diagnoses. So we know in terms of things like normal cognition or healthy cognition, those individuals who have mild cognitive impairment, as well as individuals who have dementia. And we have alongside that audiometric data. So what can we see in that cohort? Well, we see that hearing loss increases with increasing cognitive impairment. Again, not surprising, not unexpected, given that age is biggest risk factor for hearing loss, biggest risk factor for dementia. And so when we look at those who have dementia, over 80% have hearing loss. And so what I take away from this and how we think about and how we need to be talking about hearing loss among persons living with dementia is that hearing loss may be one of the most common comorbidities that comes alongside dementia. And what about hearing aid use? What do we know? So looking in the same cohort, we look, across among those who are normal, among those with mild cognitive impairment, among those with dementia. Rates don't seem to vary that much, maybe around 25 to 30% in this particular cohort of individuals who have hearing loss who actually use hearing aids. But do we see some of the same hearing care disparities by race ethnicity? We actually don't have a lot of cohorts, but the ERIC cohort is one that's unique and that is a biracial cohort that really hopefully helps us look at and understand some of these questions. And so what we do see within the ERIC cohort is that it does vary quite significantly by race ethnicity, where we're seeing among African American older adults in this cohort who have hearing loss, just around 5 to 7% those individuals actually use hearing aids. And so we know hearing loss is common. We know or we believe that there's hearing care disparities that exist, just like what we see in terms of older adults in general. But does hearing loss matter among persons living with dementia? Especially in terms of untreated hearing loss. And so one of the ways that we can look at this is to think about neuropsychiatric symptoms. And so neuropsychiatric symptoms are really some of the ways in which dementia is burdensome to both persons living with dementia as well as their care partners. And so neuropsychiatric symptoms are things like agitation and aggression, depression, apathy, many of these types of things. And so more and more, we're now thinking sensory loss, things like hearing loss. Does it put people at increased risk for neuropsychiatric symptoms? So if you're not able to hear well, you're not connecting well or engaging with the individuals around you, with your environment, does that increase the risk of neuropsychiatric symptoms? There have been a couple studies that have looked at this, but none of the prior studies have actually used audiometric data in order to look at and examine this question. So we wanted to look at this question within a clinic-based sample at the Memory Clinic at Johns Hopkins. And so what we found is that when we controlled for things like demographics and the degree of cognitive impairment, that hearing loss for every 10 decibel increase in hearing loss equated to about 1 additional neuropsychiatric symptom. And it seemed that hearing aid use may be protective, where hearing aid users had on average around 2 fewer neuropsychiatric symptoms. So if we're going to put some of this research into practice, what does that mean? So we know hearing loss is highly prevalent among persons living with dementia, maybe one of the most common comorbidities, that hearing care disparities exist, and that as we're thinking about sensory health, it needs to be really part of holistic dementia care, and that hearing care may be an important non-pharmacological intervention that we have to put alongside all of the other non-pharmacological interventions when we're caring for our persons with dementia. And diversity in terms of the trials and way in which we think about in terms of technology and our approaches needs to be really front and center when we're talking about providing hearing care for persons living with dementia. And just one last plug for the WHO World Report on Hearing represents a lot of work over the past few years and a really exciting development for our field, and direct people to it if you're looking for more on a public health approach to hearing loss. Thanks so much.
All right, well, I'm Kathleen Pichora-Fuller, and I am a rehabilitative audiologist who went into cognitive psychology because I couldn't figure out what was going wrong with all my older clients who were in the early stages of presbycusis, who were not yet candidates for hearing aids, but who were having trouble in their life. So I spent the last 30 years trying to figure that out, and now I am an older person, and I live with my husband, and he is my best case study on what it was that I saw in the clinic years ago. So I'm combining that clinical experience with my scientific laboratory approach, and I'm going to take us kind of in and out from some epidemiology, some clinical observations, and some laboratory observations. And thanks to the previous speakers for setting this up. So I would say the work I'm going to present today, a lot of the analyses were done by my colleague Paul Mick and his colleagues Lena and Roselle, who are in otolaryngology at the University of Saskatchewan. So what we have been trying to look at are these connections between sensory cognitive aging and also social aspects of it. And I would say we've heard a lot about epidemiology. This is an exciting time because we have a lot of epidemiology, which is taking us in new and exciting directions in terms of caring for older people with hearing loss and how that connects to the rest of their health. But we still need more data. We still need more evidence. We still have a long way to go. So how do we work with the evidence that we have at hand? We have to combine that with, your clinical expertise and with your patient values and expectations. So this triangle of evidence-based practice that, Sackett wrote about a long time ago when he worked at McMaster. And Kelly has kind of set us up for that. So if you're going to your clinic on Monday, you might have a patient who is explaining her lived experience of hearing loss by saying, when you're hard of hearing, you struggle to hear. When you struggle to hear, you get tired. Some of those depressive beginnings, maybe. When you get tired, you get frustrated. When you get frustrated, you get bored. Your brain is not handling this well. When you get bored, you quit. And then this individual who happened to be telling this to me said, I didn't quit today. So her victory was not quitting. And I would say that is our end game, is to kind of understand how we can help people who are dealing with a variety of age-related changes, including hearing loss, and how we continue to enable them to live well and to be who they want to be and do who they want to and do what they want to do, and not quit and not withdraw from social interaction. So how do we actually keep people staying active and being healthy? And And I'm not talking about these extreme psychiatric cases. I'm not talking about extreme cases of dementia. I'm just talking about garden variety, people who can't hear in noise. They don't want to go to the pub with their friends anymore. And we want to keep them, engaged in sensory activity, but that also gives them cognitive and physical activity, which is all good for their health. And people, as they age, they have declines of various sorts, but functioning, we can kind of counteract declines by giving them positive environments, social support, good acoustics, hearing aids, training. How do we kind of keep them functioning? And this definition of health as the capacity of people to adapt to, respond to, and control life's challenges and changes. So it's not that things aren't changing, it's what can you do as clinicians, what can we do as society to help people to adapt well? So my colleagues, Paul Mick, I've told you about, who's a neuro-otologist. Some of you may know him. Natalie Phillips is a neuropsychologist. Walter Wittich is in optometry. And we are in a national group, a team within the Canadian Consortium on Neurodegeneration and Aging. And we have been looking at data from the Canadian Longitudinal Study on Aging. So just to kind of things that you've already heard, we look at the Canadian Longitudinal Study on Aging. We can look at hearing. We see that mild hearing loss, about half of the population has it when they're in their mid-70s. But we also look at vision. And we also, in our work, always look at dual sensory. So we find the same sort of thing going on in terms of mild vision loss. And both of these things hitting half of the population by age 75. So if we look at that World Hearing Report that Carrie referred to, I think what leaps out here is that of all the people who have hearing loss, most of them have mild hearing loss. Most of these people may not even be candidates for hearing aids, but they have problems in adverse conditions. And if they're at your clinic, it's because they have one of these problems. So what does this epidemiology, what does the connection to cognition, what does it do for us? Well, just kind of taking, these are from Baldwin and Ash, some laboratory results looking at younger and older people who have pretty good audiograms. So these older people are not candidates for hearing aids. The measurement is their listening working memory span. And what you can see in quiet, regular speech, as you decrease the level of the signal, older people remember less. So this is, I think, quite shocking that if you're in noise, if the signal is just quiet, your memory system can't actually work as well as it can if you have a good signal. So, it's kind of obvious that if you do have an actual hearing loss, wearing a hearing aid would get you some good signal, and it would, immediately relieve some of that problem, let alone the long-term effects on the brain. So sensory loss, we have hearing loss alone, vision loss alone. If we have combos of vision and hearing loss, if we have combos of vision, hearing, and balance loss, the more of these things you have, the comorbidities that people have been referring to, the more this is going to relate to your general health and to your cognition. And we study cognition in the domains of executive function and memory, which Katie referred to. So now we've got our work on the baseline phase of the Canadian Longitudinal Study on Aging. At baseline, people were 45 to 85 years old, 30,000 people living in 10 different locations across Canada. Nobody has cognitive impairment at baseline. There are 4,000 different measures, clinical, biological, social measures. These measures are taken every 3 years for 20 years. And we now have just started digging into the second wave of data. So now we're looking at the longitudinal relationships between hearing loss, vision loss, and some social factors, participation, loneliness, social network, and social support. So hearing loss has an effect on cognition. We've heard that today. But what if you have some of these other things going on? Can we kind of we begin to understand how the pieces go together. So this is from the cross-sectional baseline data, and we see hearing going down according to pure tone average for executive function and memory. For vision, we have a similar decline in executive function, but not memory. Okay, so, by the way, how do your patients see? Maybe that's a very important thing for you to know. And these are effects that are over and above age and other factors that have been controlled for. And in these data, there are no sex differences. But if we start to look at, in that sample, the younger participants versus the older participants, there's a steeper slope for the older participants. So rather than, throwing out the baby with the bathwater and considering age to be a confounder, we would like to disaggregate this and look at what are the things that magnify these connections between hearing loss and cognition. So there's a clear connection between hearing loss and executive function, but it is magnified by older age. It is magnified, as Carrie has kind of alluded to, things like income, and it is magnified by multimorbidity. Okay, and for memory, we also have findings magnified by age. So now your person who's coming to your clinic, are they a 45-year-old, a 65-year-old? How are you actually going to bring this down from the population level to figure out your plan for the individual in front of you? We are just kind of in the early stages of these analyses, looking at longitudinally, what are the associations? And if you can follow my picture here, we can look at hearing, and that is going to, let me get rid of this thing. That is going to relate to social network change. It is at baseline hearing. It's also going to relate to change in memory and change in executive function. But we have also stuff going on with baseline vision that is related to executive function, and baseline vision being related to change in social support. And at baseline, we have social support also influencing executive function and memory. So this constellation of, what is interesting about your patient that you would need to take account of in order to actually develop a strategy for them to continue to age well. Social support, how does their family provide that support is something that you've probably seen in the clinic, some of these family interactions. And we know that social support and family-centered care is a big topic in hearing rehabilitation, and who gets a hearing aid and how they keep using it. So do they have the reason, because they're staying socially active, to want to go ahead and embark on some treatments? And how do our treatments actually address hearing, kind of in an obvious way, but maybe more importantly, it's how do our treatments actually affect things like social variables that in and of themselves may be a route to preserving cognition. So maybe I can put a hearing aid on somebody and that will help their cognition, but maybe I can give them opportunities for social interaction if I'm doing hearing rehabilitation that will also benefit their cognition. Maybe they do physical activity, which also benefits their cognition. So how do you tell people who have lived their lives, who all may have cochlear implants, about how to age well? There's things that we should be telling our older clients who we are seeing in our hearing clinics. So we have kind of a challenge before us that is more than just the audiogram. And now when you see in your clinic, Sally and Joan, and they are otherwise similar, but one has a hearing loss that's greater compared to the other one. Now, all of a sudden, those relationships in the association, we can understand in a different way. So Joan, who has a hearing loss, may perform as if she's 5 years older if we test executive function, compared to Sally, who does not have a hearing loss. And if she also has a mild vision loss, she could look on a cognitive test as if she's 9 years older. So we can't just throw out all the confounders. We have to actually disaggregate and understand at the individual level how these things all come together so people can stay healthy and stay active and be successful in their lives.
All right, we have about 5 minutes to 7 minutes planned for Q&A. So first question to the panelists from Dr. Cosetti. This is a great question. The United States Preventative Services Task Force suggested that there was not enough evidence to support hearing screening in older adults. Could the panelists comment on the clinical and research implications of this?
I can have a try.
Kathy, go ahead.
All right. So Paul Mick and I have done some work with American data sets looking at people who audiometrically, we would say, had a hearing loss, but who did not self-report a hearing loss. So people who had unaddressed or unacknowledged hearing loss, and they were in fact at greater risk of social isolation and cognitive decline. So I think logically, and Justin has said similar things, I think, that task force, has a standard for a certain kind of evidence that we don't have yet. But I think a lot of the discussion is around just because we don't have enough evidence doesn't mean it isn't a good idea. And I think Carrie and I are working with the WHO on how what is a practical way to move forward on their recommendation that we do actually have universal hearing screening in adults. And given that there's a 10 or 20 year lag between when people notice problems and when they come to the clinic, I think we just have to do it. And I know that people in geriatric medicine in Canada, it is part of the geriatric guidelines for primary care that people have a hearing test. So the geriatricians know they have to screen hearing. I believe there's a similar recommendation for diabetes. So, I think people are ready to take stock of hearing in their various practices. So it will come.
Carrie. Oh, go ahead. I was going to say, Carrie, anything to add to that?
No. I think just, yeah. Do you want me to comment in terms of the WHO report at all, or?
Yeah. Well, then I'll go into my next question, which is directed to you. Can you comment on some of the conclusions from the recent WHO meeting, which I know you were lucky enough to attend?
Sure. The whole, I think the goal of the WHO World Report on Hearing is really for the first time to put in some of where we're at in terms of our understanding of some of the latest evidence, but really to be able to use that as a starting point for discussions to say, there's been a lot of work done in this area and it's impacting a large number of people. What can we do in terms of ensuring that other people beyond just otologists, neurotologists, audiologists are thinking about hearing loss, but how can we ensure that hearing loss and hearing care are really viewed as a public health priority and that it is an area of action for member states and for countries. So that's the overarching goal. I think it contains a lot of hopefully useful numbers and metrics that are updated and we have for the first time in terms of kind of estimated projections and kind of economic burden related to hearing loss. And then also thinking through how are we going to meet the needs for individuals. So things like task sharing in terms of use of community health workers, thinking through development and pushing for technologies. So those are some of the kind of big picture things. And it will be followed closely with the Lancet Commission on Hearing that will be coming out as well. So those are kind of the big things happening at a global perspective to try to get other people beyond us. And I think us as gatekeepers need to be helping champion this message along as well.
Great, thank you so much. I think we have time for one or two more questions. Brad, feel free to cut me off if I need to be cut off. I'll go ahead with the next question. Do you think affordable hearing aids are enough of a solution? We have this over-the-counter hearing aid thing coming in the next year or two that should make hearing aids more affordable. But is that it, or do we need something else? Maybe Nick, you can tackle that first.
So I think it's really important to think about over-the-counter hearing aids as more than just an affordability issue. I think there's a lot going on here where they're creating potentially a more affordable option. They're also creating a more accessible option where you're not going through as many different clinical visits, but they're also changing the model of care, making it, really hearing care right now is an acute care model for a chronic condition. And if you put things on shelves and you start linking it to smartphone devices that can meet you where your needs are, it becomes a chronic care model. And that aligns more with what Carrie was just saying, actually, what hearing loss is, and thinking about community-driven approaches even. So it's really, to me, the big picture there. It also helps link who the end user is with the companies making devices, which those companies may start to take a more human factors approach even to their design and thinking about what users want and need. Because right now, I spend 90% of my life, I'm a faculty member in epidemiology. I'm not in the clinic very often anymore, hardly, literally ever. But when I am in the clinic as an audiologist, I make the decision. Yes, I take my, I take the client, patient, whatever have you, their needs into account, but I'm really making that decision for them. And the hearing aid company is really marketing to me and thinking about what I think is best. And I love the idea of cutting out middlemen. It doesn't mean that the audiologist and otologist and everyone else in the picture is not important anymore. They're still important, but it means that the hearing aid selection and the hearing aid use just changes that pathway. So I think this is a bigger holistic piece than just affordability.
Thank you. I think we have time for a quick answer to one more question. What should we tell patients who are reluctant to treat their hearing loss, whether it be by surgery or hearing aids or cochlear implants? Anyone can answer that one shortly.
Well, I think one of the reasons why we don't see people sooner is because nobody wants a hearing aid. And this is what the geriatricians tell me, that I see people all day long and I know they have hearing loss and they know they have hearing loss and their family knows they have hearing loss, but nobody wants a hearing aid. So I think we have to start offering to people who aren't yet ready for hearing aids and for people who already have them, but who still have problems, to actually do street audiology, I would say. So people don't live in a soundproof.
I like that.
They live in the community. So what do we do in the community? How do we do interventions with them that are around stigma and around healthy aging? And these are just not in audiology textbooks, but there are exciting developments. So I think we'll have more collaboration, more interprofessional collaboration, and more involvement in social policy that will take us all out of the booth and out of the office and where people live.
Excellent. Thank you. I think on that note, we will conclude this session. Thanks for everyone's attention.